Together we can do more than we can. Together holding and healing. Tomorrow is ours, no matter how far. We gotta sing to the move of our heart. We gotta and our in our hearts. In this land we belong. In this place of the stars.
Darlene, good evening. Molweni. When I say good evening, there's no response. And I get no response. Thank you, ladies and gentlemen, for being here. My name is Mosam Mushabela. I am the Vice Chancellor here at the University of Cape Town. It is my absolute honor and privilege to welcome you to this inaugural lecture, the final one in the month of August. Can you hear me now? So we're gathering here in the heart of our academic tradition to celebrate one of our own who has reached the level of professor and will be sharing with us her journey. But we also know that to reach this level, it takes a lot of effort, a lot of hard work, a lot of support as well. So I want to recognize the family of Professor Darlene Lubbe, the mom, the aunts, the uncles, everyone who's here this evening with us, the friends, the colleagues, the students. I've met some fellows as well, also coming from different countries. You're all very welcome, and I want to thank you for supporting Professor Darlene and being part of her journey reaching this milestone today. I also want to thank the faculty and the department and the division for having supported Professor Darlene in her journey. Again, I know that it takes a village to raise a child, and as we have been told before by one of our colleagues, it also takes a child to raise a village. So I think us gathering here like this, acknowledging the journey that Professor Darlene has traveled as part of the department and the faculty, it's also part of raising the department, the division, and faculty to where it is. We want to celebrate that work tonight. And I am not here on my own. I'm here together with the Dean of the faculty, who will deliver closing remarks, Professor Lionel Green Thompson. I am also here with Emeritus Professor Johannes Fagan, who is the former head of the division of ENT, and Professor Shaggy here, who will be introducing our honored guests and inaugural lecturer tonight. So why do we do this? Why do we commit in this tradition of celebrating the inauguration of professorship in the university? It is the culmination of years of dedicated scholarship, and it signals the attainment of full professorship. These are public moments, and because they are public moments, we share them with family, we share them with friends and other guests. And the talk also, even though it is coming from Otolaryngology, it will be delivered in a way that even I can understand. It will open a window into our colleagues' intellectual journey. It will invite us to reflect on the knowledge that they have built over time, often over decades, the challenges that they have confronted, and the contributions they continue to make to the division, to the department, to the faculty, to the university, and to the field at large, locally and globally. Each inaugural lecture is unique because it is rooted in the lived experience of the very academic that we are celebrating as we are doing tonight. It is not only about research or practice or technical expertise. It's also about the values and the choices and the commitments that shape a career that we are celebrating in health sciences, but also in higher education in general. So we value this as part of our own traditions in academia. These lectures help us and give us an opportunity to bear witness to scholarship that has global significance. But as you will see, the scholarship is also rooted in the realities that we face here in South Africa. This evening, we have the privilege of engaging with Professor Lubbe's work. The lecture is titled Otolaryngology Through a South African Lens, Journeys, Innovations, and Global Perspectives. While the journey and achievements will be introduced more fully in a moment, I would like to take a moment to recognize the significance of this title. Those of you present here will know, especially given the history of the University of Cape Town and Grooterschuur, that in this place, medicine and surgery is often linked to cutting-edge technology and highly specialized knowledge. Her career will show that innovation does not only originate in well-funded settings in the global north, but it also comes from a place of constraints. The need to do more with less stimulates innovation, and the resilience and creativity required by the South African health system. In this way, her work reminds us that academic excellence is closely tied to our very social context and reality. And it's these kind of lessons and stories that we get to witness that make these inaugural lectures even more special here at UCT. This is why they matter. They remind us that knowledge creation is not only abstract, that it is shaped by the location in which it is generated. It is shaped by the trajectories of the history and the journeys that our context has been through, and the urgency of the real world issues that we have to confront. These lectures also urge us as universities to consider how our scholars respond to challenges, how these responses can be supported, and how they can impact global practices as well as local practices. And this is why it's so important for us to commit to supporting them as part of flagship engagements. Personally, I like them because I get to witness the scope of work that our established, our esteemed, our distinguished researchers, the work that they do, I get to see it. I also get to learn a lot, and I get to share the stories when I engage with our stakeholders across the institution and elsewhere. I sound smart when I talk about their work. And I want to continue the tradition of making it a proud practice of recognizing the production and development of scholarship that extend beyond our borders. Our greatest strength is that this work always begins at home. It is rooted in our local challenges, the needs of our patients, our students and communities, and yet it's got global impact. As a university, we take pride in the ability of our academics and researchers to connect the local with the global in a way that makes sense, in a way that is unique to us. So as we listen tonight, I encourage us to reflect on the broader significance of the work that Professor Darlene has produced and her insights. Her work will resonate, and it will also include aspects of mentorship, training, and innovation that define a full professor here at UCT. Thank you for joining us tonight, and allow me to invite Shelva to take the podium. Thank you very much.
Thank you very much, VC. Unfortunately, Professor Lydia Kingcross, the head of Department of Surgery, couldn't be here today. And I graciously accepted to fill in on her behalf. And what a treat it is for me, actually, to be able to introduce Professor Darlene Lubbe for this incredible inaugural lecture. I've known Darlene since I was a registrar, and I must say she's been a mentor, she's been a teacher, she's been the cavalry when we had a difficult case and she came in to assist us with that. She's been a colleague, and she's been a friend. And for me, she's been a true inspiration. And for so many of you in the audience, I'm sure you can attest to that. And for those many, many people all over the world who she's truly inspired. I want to just mention that the both of us were invited as guest speakers earlier this year in May to attend the Australian or Australasian ENT Society Congress. And I had the privilege of observing her in her element. And she was teaching workshops, presenting, and she managed all of this with such grace, but also with such integrity and humility. And I was really blown away. And we sat down on this amazing speedboat jet that we never would have had before and discussed this with all of the organizers. And we came up with this phrase that really describes her. And it's something that I just have used since. Darlene is a rock star. And you are to me and to those of us who get to be with you every day. Lydia has left a message, and I've agreed to kindly relay it today. And I think it is actually a wonderful message. Congratulations on your inaugural lecture, Darlene, and my sincere apologies for not being here to share your evening. It is my loss. I had the privilege of presenting Darlene for ad hominem application for professor, and in that process, came to know of her incredible accomplishments in full detail. And of course, we knew some of them. Prof Lubbe was the one to call for an impossible airway. I'm sure some of you in the audience know that. Someone who could help you design a new surgical device to make an operation go better and faster. She was the surgeon who identified and figured out how to use literally new pathways to access the base of the brain. And she did all of this quietly here at British Care Hospital while simultaneously presenting this work on multiple global stages. Through the ad-hoc process, I learned further of her sheer scale of her continuous innovation, her technical brilliance, and the reverence with which she is esteemed in the international community in her field of work. More recently, Darlene has been working on the alarming possible association between long-term Depo-Provera use and the base of skull meningiomas. Her courage and academic integrity in bringing this work into the public domain attest to her full complement of skills as a clinician, academic, and surgeon. The skilled technician, the innovator, the discoverer of new knowledge, and the advocate for patients under her care. As the Department of Surgery at UCT, we are proud to name you as one of ours. Congratulations, Darlene. And so from me and all of us from the division of UCT, Division of Otolaryngology at UCT, all of you standing and sitting with us here today, it is with great pride and beaming excitement that I invite you, Professor Darlene Lubbe, to give you an inaugural lecture.
Thank you, Shazia. And Shazia has just become our new head of department. So I've given many talks in my life and many keynote lectures, but I think I'm most nervous about this one. It's the first time that I have to speak to my friends, not looking at faces because they're going to be giggling and putting faces, and my family. And it really is a great honor to have my close family here. So I'm going to try and do that justice. So normally we have disclosures, all the companies that we work with, but none of that matters. So it's disappeared. Disclosures, all of you here today, except for my dad, who passed away in the first COVID wave. And so all our medical doctors not seeing our family during those times for weeks, for months. I could not even see him before. I'm sure it would have been very hard. Unexpected. So the story starts in 1995. When I was a very average student. I mean, if you listen to students and some of the people here that shadows me, 11th graders, and everybody gets 95% or 110%. I'm like, wow, I really was a very average student. I was very happy with 65%. And I thought I was doing well. So I was really middle of the class. I mean, in school I did well. And then when I qualified and I studied surgery, I suddenly just enjoyed what I was studying. It was amazing. I just loved what I was reading. And when I went into that exam, there was nothing that they could ask me that I didn't know. It was the nicest, coolest exam and feeling I ever had. To such a degree that I won the surgery prize. I was called the Dark Horse. You know, there were people that were really cheering for this prize, so they were disgusted, to say the least, that I came from nowhere and won this Ethical prize. And those years, it was still called the Zuma years. You had to do 2 years of being a medical officer and going somewhere. They could place you anywhere. But because I won this prize, they said to me, you can skip this process and become a registrar and general surgeon immediately. But there's one, so you can skip your 2 years. There's one condition. You're not allowed to change. You can't go to ENT, can't go to neurosurgery, ophthalmology. And I remember as a medical student walking past a surgery where they were busy doing some big colon operation. I was like, oh, I definitely cannot spend the rest of my life doing this kind of surgery. So I said, wow, that's a tough one, but actually not. So you know what? Thanks, but no thanks. So I wasn't really angry. Yeah. So I took a year off to do other stuff. I thought, what am I going to do now? Now I'm right to the back of the line. They said, don't come and knock on our door. This is the one with invitation. So the other stuff that I did, my dad said, why don't you come and work for me? He was a very well-known, famous cardiac surgeon doing very complicated revision bypass cases. I said, what on earth will I do? He said, well, you will harvest the supplement glands that we do use for the bypass surgery. And it's a really important job. Because if you mess this up, I have to close the patient up and you have to go tell the family, sorry. So that was a really important lesson very early on for me. And that's what I did from 8 to 1 every day. And the rest of the time, I did karate. And that was my biggest dream because I've always wanted to be Bruce Lee. Bruce Lee was my biggest mentor. My whole room was just Bruce Lee. I had every pair from chakra, every picture that was ever made of Bruce Lee, every movie I watched. I wanted to be Bruce Lee. And I started karate at 6 years. You can already see I had some badges there, being the South African championship. And my biggest wish ever was to take part in the World Championships and get my Protea colors. And that's what I did that year, working for my dad. I had fun. I did karate. I went to Australia with my friends here, and Smitty, Sonette Smith, my karate instructor, who knows me from the age of 6 years, which is in the audience here, has really been by my side during all of this time. During that year, I also thought, let's make some money. And that's me. They showed. Maybe I didn't manage to shatter it. I can't remember. So after that year, I started on my ENT journey, and that started in, I can't quite say it yet, but it was Port Elizabeth those days. And I really had some key insights working in this area. I was a medical officer in ENT. I had no ENT knowledge. I wasn't a great ENT student. And I had 6 consultants, private consultants, who kind of taught me how to do grommets, consults, all the basic. basics. And I really realized the unique challenges and the constraints that we had in a resource-limited setting. And in those days, PE, and I still think it is a resource-limited setting, you don't have specialists with special kind of techniques and instrumentation. There's many inadequate, unavailable treatments, not just in that remote area, but also in the ENT field. And this started with an old lady, one of my very first patients, came in with a terrible nosebleed, and I had to pack her nose, and I was sitting in front of her, and there's this horrible way of controlling nosebleed where you pack this 2-meter piece of material in someone's nose, which is so painful. And she just went back and back and back, and I just went forward and forward. And then she went back, and I kind of watched what was happening, and she sneezed. And my whole face was full of blood. And I'm like, wow, this is not cool. Then I was told she had HIV. Why didn't you wear glasses? So I had to have antiretrovirals, and I got full-on Guillain-Barré. I was in hospital for many weeks with my mom flying up to come and visit me in the hospital, and Karen is going to say here. So I learned that the really necessity kind of powers innovation. There's a need to find new ways to do things to help people. But you can only do it if you collaborate. And if you collaborate, it multiplies the impact. I see so many times that people try and do something new, something innovative, and they want to keep it for themselves, and they try and do it on their own, and then they don't go anywhere. So if you don't have a team that you can work with, you really can't have an impact. And I identified all the other speciality. There's such cool instruments, such cool things, like can't be used this in ENT, can't be used that in ENT. And that's where it started. And then I started my registrar training. I was very lucky. John Black had contact with Jan Fagan, and I managed to get into the program and started my registrar training. And in those years, I didn't know about dementia. I didn't know that you needed to sleep 8 hours a day, otherwise you're going to get dementia. I didn't realize that if you wanted to remember what you studied, you had to sleep 8 hours a day. Those were the days that you studied till 4 and got back up at 6 in the morning and quickly crammed something before your 8 o'clock class. And that's exactly what I did for my final exam. There were 6 people that went to this exam. I was the only one that went through. And Johan Franklin was my boss. He said, Darlene, you're going to win the gold medal. You're going to do this. Because I was the only candidate, Prof Fagan had to go to the States. He said, you're going to be fine. So I went to go do my exam. And I thought, you know what, I just need a little common tablet. I'm going to take a little bit of it. And then on my way to Tigerberg, I could see Tigerberg, the exam was over there. It's a new professor in charge of the exam, internal exam. I thought beta blocker. I took a blue tablet. This is what? So what did I take? I took a sleeping tablet. My exam did not go well. It went very well. But for that and for many other reasons, I disappeared. I was on call that next day. I didn't come to work. I wrote Johan Fagan a message saying, I'm done with medicine. I won't be back. Nobody could find me, my family, nobody. I disappeared. Can't get married here. Just meet with me in Honeston. And Johan Fagan somehow found me after 2 weeks. He said, you have to come back to me. You have to do this again. I'm like, no. And he said, you have to. I'm like, no. And eventually I did it. And it took me only about 20 years to get over it. But there's definitely some lessons to be learned. Don't take any tablets. Sleep 8 hours before your exam. Don't write your exam early. So I would like to speak about my mentors and those people who shaped my path. Often lots of little potholes and puddles. And the path is South African style. So that's what I would like to tell you. So these were kind of really important mentors for me. John Black, who I still call Dr. Black in Port Elizabeth, and who taught me everything I knew. He as medical officer who now refers to me. Jan Fagan, who will forever be my mentor. Heinz Steinberger, who is the god of sinus surgery. You really, I was very lucky to spend some time with, and he came to support me every 2 years with a course. And he very sadly passed away a couple of years ago. Rick Corral, who I'll talk about, and then he's still my mentors, Chris Murray. And then people always ask me, it's so strange, you only have male mentors. how can you only have male mentors? Not true. I am select split. He's in the middle here, who has known me since the age of 6 years, who really was my mentor and taught me a lot during my years of karate. Every time I did a kata, I'm like, wow, that was good. I know that was good. So you come by and say, good again, not good enough. So I really believe that sport during your career makes a massive difference. So Johan Fagan said to me then, as I qualified, did not go the second time. After he said to me, I said, I want to go do a fellowship. He said, there's a post available for this year. I want you to take it. And he said, I really want to do a fellowship. He said, well, to get a post, you have to wait for someone to die or retire. I mean, to prove your point, I've been here since 2000, so it's like 25 years. So I said, okay, all right, let me take this post. But obviously I have a big chip on my shoulder and I'm not doing a fellowship. So I did my own fellowship. I had a little golf cart with this tiny little cold storage screen, is like 2 by 3 centimeters. All my tools, we got all the permissions to go to Salt River Mortuary. And every day I went down there with my golf cart. And there would be 4 bodies on slabs with a little toe sticker. And as a part of the post-mortem, I will do a post-mortem on the nose, on all these. And I must have done hundreds and hundreds of nasal post-mortems. And one of the things that I learned right in the beginning, when you kind of stood there in that empty room and the police van left me, kind of a little bit of blood on the floor, it's like, it really doesn't matter if you live on the street and you drove around the Vol Drive with your Ferrari and you missed the corner. You're going to end up here. You can't put your Ferrari or your gold watch in that little box with you. So, and you also can't put 100 articles. So what's the point? If we do we really need to write all those articles and things? But I did it anyway. So it started. Johan Fagan was really good in pressurizing us or telling us to do, but it was really fun. And you'll see, kind of start slowly, and then I think for the professorship I had to do 70 or whatever. So did those articles. It was really a lot of work, a lot of book chapters, and I still find myself writing. I don't always know why, but I still find myself writing. So then Johan Fagan says, why don't you go and visit Rick Corral? And he was in Pittsburgh those years. And this is where I started a couple of months. And he taught me everything that I think I know today. They had this amazing cold sports OR1. It was one of the first operating room theaters of this kind of sci-fi. And we had watched him through these kind of glass windows every day operating. And I had this patient, she's also in the audience, Jane, that had these 2 little kids. I think they were 1 and 3 years old. And she was diagnosed with this malignant melanoma, which is a horrible, horrible disease in the nose. The same as skin, but in the nose, it is much more aggressive. This is what it looked like in the nose. And Rick Corral said, Rick, can you help me? Or Dr. Corral, can you help me remove this tumor? And he sat next to me at this really fancy course, which he let me do for free. He sat next to me for 3 hours and taught me how to do this procedure, which I came back and I did it with the limited skill that I had. And what you see there is basically just a big hole in the nose, one open, empty cavity. And because it was such a big tumor and such a big cavity, Prof Darlene is also in the audience here, said, why don't we do a kind of a brachytherapy implant, which is your radiotherapy implant. And this was the first one, I think, that I know that we ever did in the nose for melanoma. And Tasneem, who was a registrar then, also in the audience, wrote this paper and presented it. And today, I thought Jane's never going to see her kids go to school, but 20 years later, I still see her in the clinic on a regular basis. She's completely disease-free. And this is, I think, thank you to Rick Corral, who doesn't even know that he saved a specific patient's life. And many thousands of lives through me and through the people that I managed to train. And I think that is the value of a mentor, people not even knowing that the impact that they have on other people. This is Jane today with her two daughters, who both have gone to university. So since then, even although I didn't do a real fellowship, we started under Jan Pagan running a fellowship program, and the pediatrics under Shazia, otology under Tasneem, Jan Pagan and Matthew White with the head and neck, and I did the rhinology and the skull base, all sponsored by Carl Storff. Usually for people from sub-Saharan Africa, but we've had people from Turkey, Oman, Belgium, and my latest fellow from Mohammed from Kenya. There's Ahmed from the UK. So you can see all of these people, many of them have become professors, and some of them have started their own fellowship programs across Africa. And this is the only training program in Africa. So we really see advanced tumors in South Africa. We see things here that it's not often found in the rest of the world. And Prof Hagen is known for doing all of these resections open. I remember as a registrar, we called it a hemihedectomy. It's like, what's on the list today? It's a hemihedectomy. Because the first time I went into that theatre and I saw this patient, his face had deconstructed, I felt a bit ill and lightheaded. I thought, but how are you going to put it all back together? So I do the exact opposite. So if the patient's skin and the muscles of the face are not involved, and you can go minimally invasive through the nostrils, then I will remove it. So either you go to Johan Fagan or you come to me. So when he showed me this picture and he said, I've just seen this patient, can you do something next week? So I said, no. I mean, look at that. You don't need to be a doctor. I mean, that's massive. It goes into the brain, it goes onto the dura. It looks like there's involvement. There's no way I can get this out. So he said, well, just speak to Alan Taylor and the neurosurgeons. They'll help you, Patrick Simple. And I went to go speak to them. They said, you'll be fine. Just do what you can. And what you can't get out, we'll come and get out later on. So, okay, well, great. So this was in 2014. There were limitations to us. We didn't have what we call navigation, the GPS system that we operate with now. We didn't have the fast power tools, so the surgery really took long. Limitation with the instruments, limitation with neurosurgeons trained in kind of advanced endoscopic work other than pituitary work. And reconstruction was an issue, meaning that if you remove that tumor, the brain is just going to fall into the nose. So you need to, it's okay to remove it, but you need to be able to fix that brain fluid looping. So this was one of the first case, one of those first cases, early days, where maybe a little incision in the eyebrow, and then kind of just, okay, well, I'm going to just do as much as I can. So putting out the tumor, removing the tumor, and just piecemeal by piecemeal. But what was really interesting is things that I learned early on, where you see an MRI scan of that, and you think the patient has got extensive dural or meningeal involvement. And here you can see what's happening here at the bottom is that the tumor is being peeled off that meningeal layer, the lining of the brain. And you can see it looks healthy. So you can start wondering how many patients don't get offered surgery, or the eyes get removed, or they don't get offered surgery because of feeding that is too advanced. So these patients are still seen on a regular basis. This was his last scan in 2023. But it just shows you that there are alternative approaches, and we have to adapt to whatever is available to us. You have to adapt to your tools and to the specialities that are available. And it's possible. We basically have good results. I mean, this is the last patient scan last year. And you can see a beautiful open plan nose, but patient on skull, but he really is alive and well with a very good quality of life. So this is where I've been super lucky, because I really absolutely love what I do. And I've never hit the jackpot, but I hit the colleague jackpot. I work with wonderful colleagues and people that have become my friends. And they're always going for tough cases. And I can see Ross Hoffmeyer, Professor Hoffmeyer, who does the anesthesia list for me on those Tuesdays. And we always say, I used to phone him, it's like, Ross, are you with me on Tuesday? And I said, I mean, am I with you? Or are we together? Because the anaesthetist will always kind of work actually with the surgeon. You're supposed to say the anaesthetist is working with the surgeon, not the other way around. But I will always phone Ross, and I'll say again this week, I said, Ross, are you available this Tuesday? We've got a really challenging case. It would be nice to have you there. So we try things, we test things, we fine-tune it over and over, and we continue to do it safely. So I thought I'd bring this as a new, not a little, it's a big robotic called the V-Charm Eagle from Carl Storch. And there's some people from Carl Storch here, and we've got this machine with us for worth about 6.5 million that we're playing with for the next month. And I'm showing you this picture. There's Matthew White, it's Ross Hoffmeyer standing there, and we're busy doing a very complicated, tricky case. But look at the smiles on their faces. They didn't even know this picture was being taken. Just absolute glee at what they're seeing. And what they were seeing is they were looking at this picture of the traculator balloon being kind of really in 4K and in 3D on this V4 machine. But there's been patients, many patients, that have changed my life in the way that I do things. And David is here with his family, is also one of those patients. David was really, I think, his mom said to me, age of 12 or 13, when he was introduced to me by Prof Alan Taylor and Jan Fagan, when he had a massive, really large tumor that was found to be irresectable. And he had previous surgery, and that's just his picture from the Reach of Dreams. And they said, he's really struggling to sleep. Can you at least first provide a nasal airway? And I'm like, but how long will it last? Will it get, everybody said, well, it doesn't matter. Just go in and try and see what you can do. So we went in, and David is there today. He's 37 years old. And last week I had to write a letter to say David can have his own home now. It's just around the corner from his mom's. But he is, and that shows you the results that we can get. And you can never give up on a patient. And this is really because we've got such a strong skull-based unit. And this is Hamza, Mushtaq that I've worked with. And none of this work is possible without the colleagues, the neurosurgical colleagues, Byron, Alan Taylor, David Lefevre. These are the neurosurgeons that have to do the embolizations before I do the tumors. I can't do a tumor case before it's embolized. So it really is all teamwork. And I got a job offer earlier this year in the Gold Coast, and I spoke to Johan Fagan, and I said, Johan, what do you think? I'm not going to go, but what do you think? And he said, no way. He said, you don't have Alan, you don't have David, you don't have Byron, you don't have Hamza, you don't have Ross. I'm like, okay, stop, thanks. So, and it's true. It's you can only do these cases if you have your team around you. And this is Anita van Rensburg. She's also in the audience. She's my scrub sister forever, since probably 2003 from Panorama. She still helps me at Mini Clinic, and she's really one of the team. And I always say to her, if I drop dead, you know exactly what to do. We've got the sign language that I don't have to tell her what instrument I need. It's just all the way that you hold the hand, because that's how the instrument kind of goes into your hand. So like this is the Blake seal, like this is the keratin, and she knows. And I said, we have to write an article about the sign language. And then when I started, Johan Fagan was doing all the pituitary surgery with Patrick Semple. It's also here, and Patrick has been cool wearing his glasses in theatre, so actually 3D goggles that we tried out many years ago. And we worked together from 2003 to up to about 2 years ago. And the pituitary surgery was all done with a microscope. And Johan Fagan would literally do it in 5 minutes. He would use the headlight, quickly find a way through the nose, and then say, okay, Patrick, you take over. So when I came, it's like, Patrick, I can't use that headlight. I have to use my endoscope. And he was so irritated with me in the beginning. I was like, just, I'm sorry, so you're taking so long. It's taking a half an hour. And we just did the first test with the endoscope. And then he saw the picture and was like, maybe we just carry on with this for a little bit. And the microscope never came back into theatre. So Patrick then trained Byron, and that's Byron on the side there. A little bit of a height difference between us. So I am worried about Byron's neck if we have to work for the next 20 years. So this is one of the articles that was in the newspaper about when we started transorbital surgery. This is well, we know Patrick. He's never had his mask on his nose. You can always recognize him. And this is and Patrick said to me, we were watching two of our fellows, we each have a fellow, we were watching them operate. And I said to Patrick, I went out, I'm like, you can't believe what they're doing. They're just really not listening to what we told them to do, and they're doing it this way. And he said to me, Darlene, we didn't train them to do it like us, but to do it better than us. And I'll never forget that. It was a really important lesson. So this is a case we did borrowing last week. We've been playing around with a new kind of dye in the system called the ICD. You can beautifully see the carotids. So we really try and make every case fun. This was a pituitary tumor, and you can see how that dye lights up the pituitary tumor. And Byron very nicely found this small little tumor that made this lady really ill. So how did we get onto transorbital surgery? This is really thanks to Chris Moe, who is still my mentor today and a great friend. We've written so many book chapters together. He's from the University of Washington. And I watched him do a cadaveric dissection in Vienna about 2015, 2016. And I was just absolutely fascinated by, this person going through the eye. People always say, do you take out the eye? No, you just squash the eye to the sides. You either squash it left or squash it right, up or down, and then use that little pathway past the eye. And I came back and teamed up with Hamza Mustak. And Hamza was a registrar during those days. I was already associate professorship, so everybody's a little bit baffled by our kind of friendship. And we really just spent so much time in the cadaveric lab. Then we operated on a lot of blind patients who would have lost their eye, but we could operate for them to keep their eye for cosmetic purposes. Then we operated on people with compromised vision, and we've reached a stage now where we go through the orbit in people with completely normal vision, for people with brain tumors or eye tumors. It wasn't Hamza and myself operating. We spent many days together. So we have a unique problem in South Africa, and this is something that I realized doing many talks at different conferences. You see, this is basically a meningioma, a tumor that's on the skull base. And we instead of doing a craniotomy, we come through the eye, through the corner of the eye, and through the outside of the eye. And at many meetings, I would always present these tumors, and I was always asked, and a lot of them are neurosurgery meetings, and neurosurgeons can be quite aggressive, except our neurosurgeons. And they would always say, "Hey, Darlene, when did you do your last doing meningioma?" And I'm like, "Well, Friday, last week." "Well, when are you doing your next one?" "Well, next week." And they said, "Well, that's impossible. We the biggest unit in France or wherever, and we do 10 a year." And I was like, "Well, we do 10 a month." They didn't believe me. So this went on and on until they see the publications that came out and how we managed to preserve people's vision. And it was actually a neurosurgeon from Australia, Charlie Teo, that spoke to us and said, why are you not publishing it? I said, what's to publish? And he said, the fact that your patients are seeing better. I said, well, it doesn't always happen when neurosurgeons operate. And he said, no. And that's when we realized, okay, we're onto something here. And we operated on these patients, and this is a book that Paul Stoltz wrote on the transorbital approach to splenectomy meningiomas in 2016.
In other words, they need to find out more about the association between MPA and brain tumors. So Professor Lubbe started to phone her patients one by one to ask if they had ever been on this high-dose contraceptive, which is routinely offered to women in low-income countries.
And we were talking just things to each other. And
one of these was Caroline from Fishhook in Cape Town, who described the injection as a way to address endometriosis, a painful condition of the uterus.
He said, Deborah is not always hypertonic acetate. Nothing the penny dropped.
So when this came up, I thought, okay, finally,
This
seems to me to be the reason.
And we found that 100% of our patients all were women, and they were all on Depo-Provera. I said we almost see more patients in our clinic than we do see patients with tonsillitis. So I said, Byron, we've got a problem. We need to do this faster because one of these operations can take us 8 hours. So we spent many hours in the lab and we thought, is there a possibility that we could operate at the same time using 2 teams with me going through the nose doing optic nerve decompression and then Byron going externally through the orbit. We also started using 3D models, practicing in the lab to do this work, and then taking these models to theatre and seeing whether our instrumentation would work and what the angles would be. And this is us operating. You can see very narrow space, surgeons around a very small kind of surgical field. And on the left-hand side here, there's 2 surgeons already going through the eye, with 2 of us working through the nose. And we've managed to bring the time period that we do, or the duration of the surgery, down quite dramatically. So we also discovered that, how to treat these tumors, really you need to do an optic nerve decompression first, which means that you have to take the pressure off that optic nerve before you address the brain tumor and the tumor that causes problems. And this is what we became well known for. Since that, we have now established the Endoscopic Transorbital Society, which consists of 6 neurosurgeons and 2 ENTs, myself and Chris Murray, that basically teach this technique on different courses worldwide, writing textbooks and ways to do the surgery. So you can see that necessity kind of powers innovation, and we kind of fought to find ways to do things better or quicker. So during all this exciting work, the skull-based work, the transorbital work, the nasal work, unfortunately, for some reason, or not unfortunately, I should say fortunately, for some reason, I was also the airway person. So what happened was every time there was an emergency airway and a patient came in with a kind of what we call striders, and they would come in not being able to breathe. And often people would confuse that with asthma, but it would often be after people were ventilated or they had bad accidents and they were lying in the ICU, and we specifically still after COVID. It's a very, very hectic surgery, life-threatening, and you need the most senior anaesthetist and, the most senior anaesthetist to manage these problems, also the most senior ENT surgeon. What would happen is you would have a patient that would have a very, I'm just going to go back a little bit, you would have a very narrow airway. So you're looking at vocal cords, and you see a tiny little hole that's smaller than a straw. That's what a person is breathing through. So what happens is, it's frantic. It really is. This is ChatGTP, and ChatGTP actually, quite interestingly, put the mask of the anesthetic machine, the oxygen, underneath it. That's pretty true, because it normally is underneath it is really painful. So what would often happen if the most senior person wasn't around, the patients would end up with a tracheostomy, and that would really make further surgery difficult. The surgery that Andrea Brooks and Charles appeared in here, and they're starting to help us with some of these patients that have permanent tracheostomies, and we need to cut away the kind of the bad segment, which is really difficult if someone does a tracheostomy first. So I was told for all of these cases, and I was still crazy, and thought, and then we would take the patient to theatre, and you would do what you call a bougie dilation. So you would have these perfect dilations in textbook at the top right, but at first they look like this. So by the time you get to theatre, it's like, how should I get that through down a straight bronchoscope? So you would have to put it in hot water to kind of make it malleable. And it was very traumatic, because you wouldn't, you lose sight, so you don't really know which area you're stabbing. It can cause a lot of trauma. And often what would happen is a patient might rest, have an emergency tracheostomy, and I'm putting this up especially for Ross, because they take out this machine, it's called the jet ventilation, and the anaesthetist, especially those that panic, will blast a bit of air onto that little hole to try and get a little bit of oxygen through. And I'm like, no, don't do that. And it would be too late, because the blast of air is like air pressure of a tire. It would go straight on that little hole, and it is swell shut. And the few minutes that you had becomes 3 seconds. So I went to a company and said, can you help? Is there a way that we can do a safe dilation? Can you make a balloon this long? Can you make it that the patient can be ventilated through it? Just to take all the stress out, that anybody can do this procedure. So they developed this thing, and then Ross did mannequin testing, and we did the poor sheep. Sorry, Mom, I wasn't involved. And Ross was involved with the sheep problem. And so we did all of these kind of fancy studies and published it. And basically, all of these fancy things so that the balloon worked very well, that you could ventilate the patient as you could ventilate someone without having a stenosis or a kind of an airway problem. So the idea was that you have these 8 balloons in a circumferential kind of fashion that inflate, and you have the central inter-balloon space that remains open, patent, and the patient can oxygenate. And literally, I sit in the corner, and or the registrar says there's a dilation. I'll say, "Good luck." So I don't actually need to be there. In fact, the anaesthetists often do this procedure now. And I was allowed to do the dilations, and we've done over 400 cases with Ross Hoffmeyer writing his PhD on ventilation techniques for patients with this problem. So it really has made a massive difference for us avoiding tracheostomy in that immediate situation. So, and in some cases, patients don't need anything further. They might need one more dilation. Sometimes they can at least get definitive care. So we did prospective trials, and this was really published in Journal of Cardiovascular and Vascular Anesthesia, a very big journal. And then in 2021, we went on and won the Gold Winner in Medical Design Excellent Awards in the United States. And the only reason I'm putting this up because the Da Vinci robot came second. That was quite a new feat. So we've done really well with this balloon. And don't see Mark Blockman in the audience, which is good, but I did have a bit of a stenosis, so Ross has helped me out here. But what we tried to do here is we wanted to see, because of our theatre lists that are being cut, we can't get patients into theatre. Often patients are too sick, they might have eaten, so we can't wait for 6 hours. So I said to Ross, let's just do it. Let's blow the balloon out of my own throat, my own trachea, and let's see how uncomfortable it is. And he said, great. So this is us in the recovery room. I'm holding the endoscope. You can see I've got a high flow oxygen, and the picture on the right is the balloon going up at 6 bar. So that's 3 times the car pressure in my trachea. And I was able to speak to Ross, and was quite comfortable. And I cut off the bit of the video. I said, "Crank it up, Ross." And he said, "No." So from here, we really proved that it was possible to do this. And subsequently, we do, not often, but we do patients in a awake setting where anesthesia is too difficult or dangerous. So then we often get sidetracked by other things. And someone heard we've got a balloon, and then you're getting help this dog, and he says, sure. And then with the help of Carl's thoughts, we did this Indy. This is actually a turbinoplasty, and Pedro Montero is my fellow, and he's in the back as well, helped me with Indy. And then he said, well, can you do also? Well, I'm like, sure. And but I needed a team. So this is Conrad Pino, who's a really well-known plastic surgeon who works with mental wife, Jan Fagan, and this also their cleft palate. And we only found out afterwards that the mother was a very valuable kind of horse, and they wanted to have the horse have little babies. So this went really well, and that is the horse a year later, and she did manage to have her own little foal. And this was from Indy's owners. Thank you. It only takes one person and one act of kindness to inspire others. Sadly, Indy did pass away of obstructive sleep apnea, which is a common problem in these dogs. But it is quite, and it really makes it interesting working with other disciplines and other people. And it was amazing to see that the veterinary surgeons do exactly the same surgery that we do. They just don't wear gloves and they do it outside on the grass. So on this horse, we did a tracheostomy, and I was like, wow, I've got 30 minutes to choose from. It's really amazing. So almost done. So what are we working on now? So I think that's the value, or the kind of the fun of working in a place like Grooterschuur, the University of Cape Town, that there's all these challenges that we have. And there's this one condition, hereditary hemorrhagic telangiectasia, where it's a bleeding disorder, where people have all these blood vessels that are abnormal in their nose, in the lips, in the stomach, in the brain. And the big thing is that they bleed. The ones from the nose can bleed so much that they really have to have transfusions almost every week. Some of them can't even leave their homes, and it's a familial thing, so the whole family suffers from it. The only treatment that really exists that is proven to work is basically to close the nose. They call something called Young's procedure, where you suture up the nose. So no more breathing through your nose. I did it once, and I kind of reversed it the next day. It was just, I thought, horrible to do it. And there was a person from the hematology department, a young lady that had HHT herself, and she came and she said to me, "Can't you give me a bleomycin injection in the nose?" I said, "Absolutely not." She said, "But I've had it for 10 years and it works." I'm like, "Well, we'll go to you, And I started reading up on it, and all the kind of things that we believe, you can't inject anything in the nose, you're going to cause blindness. A lot of those things were fallacies. There were certain reasons why people went blind. If you injected steroids, for instance, it was particulate matter. But bleomycin is a chemotherapeutic agent. Yes, it's got risks involved, but there was some evidence. And this has changed the life of these patients. It is quite phenomenal. We've just written a retrospective, and this is the very first patient. This is in theatre. This man could not leave the hospital. He could not have a brain surgery because of his severe epistaxis. This is me trying to suction up the blood even while he's asleep, just to try and control it and see where he's bleeding from. And we started giving this bleomycin sclerotherapy, and we said to him, "Listen, we're not sure it's going to work. It's basically 3 mils of this chemotherapeutic agent that you inject. And there are certain risks. You can get pulmonary fibrosis. You have to be careful and watch these patients." And now we do it for many patients. We've done 12 patients, most of them elderly patients who really are quite desperate and have nothing else left. But the treatment is quick. It's a couple of minutes. You can do it in the rooms. It's doing it mostly in theatre. And you'll be using something called the ICG. And you can see how they light up. And to my knowledge, this has also never been described. We use this substance, intracellularly green, the anethidus, injects it into intravenously half a minute before you want to see the vessel, and then you see all of these vessels show up. But interesting, so far it looks like the specific vessels that bleed are showing up. And this allows us then, with really under direct vision, to go and inject each one of these vessels. And a patient that's got 300 units in their lifetime before they have reached the toxic dose. So we have 3 units at a time. So I say to them, "Well, you've got 100 units, so I think you're going to be okay." But it's still perspective. But this is also something that we're doing with our hematology colleagues and pulmonology colleagues to really, and I think this is something that will change thousands of patients' lives worldwide. So what else? You have to come and ask me what else we're working on. You join us at the Neuroscience Institute after this full glass of wine. Thank you so much.
Wow, wasn't that amazing? Absolutely fantastic. But Darlene, congratulations on that wonderful presentation, and thanks for sharing your remarkable professional journey with us. And congratulations also on your full professorship. It's so well deserved. I've had the privilege of knowing you since 2000, when you first joined the division of Otolaryngology at UCT, initially as a teacher, and over time as your friend, your colleague, and now a big admirer. You are an exceptional clinician, teacher, and surgeon. We watched you pioneer and lead the field of complex anterior skull-based surgery, as you illustrated to us, becoming a world authority in this. Your determination to solve clinical problems has driven some meaningful innovations such as the traculator, which you showed us as well, which is now the global standard of care in managing airway stenosis. But beyond your clinical excellence, there are many other qualities that deserve recognition today. Your unwavering commitment to patient care, your dedication to teaching and training registrars, fellows, and colleagues, your vision to develop rhinology across Africa through the continent's only train-the-trainer rhinology program, your multidisciplinary teamwork, as we saw, through collaboration with disciplines such as neurosurgery, ophthalmology, radiology, oncology, and anesthesia. Your principles and ethical partnerships and relationships with industry, and the integrity with which you also conduct your ROPs. I know it's been a controversial discussion in recent years, but this has benefited not only your private patients, but also the public sector, your trainees, your colleagues, and UCT. And given the limited theatre time available at Forestry Hospital, the additional surgical opportunities provided to RVOCs have been crucial to your clinical, academic, and your research success. And finally, I'd like to also acknowledge or recognize your love for Cape Town and South Africa. With your credentials and achievements, you could have taken up a position anywhere in the world. Indeed, as you pointed out, you turned down a highly prestigious offer of a chair of ENT in Australia to remain and continue serving the people of this country and the city and this continent. I'd like to conclude with the words of our colleague, Professor Raymond Sachs, who's actually from Johannesburg originally, but he's now the president of the Australian Society of Otolaryngology, Head and Neck Surgery, and vice president of the Royal Australasian College of Surgeons. And he said to me recently that the only problem with Darlene is that she doesn't realize how good she is. And I think that speaks to her humility as well. And so, Darlene, we are so proud to celebrate this milestone in your career with you today. Thank you for sharing with us.
Aanvangs is de belangrike geleentheid in die gemeenskap van die universiteit. En die les wat Darlene nou afgelewer het is Afrikaans I wanted to say to Darlene's mom and to her sister, welkom aan die fakulteit. Is nie baie keer wat ons saam kan wees met familie. En net om saam te vier die werk wat mense doen in die fakulteit. So dankie vir julle wat haar aan ons gegee het eintlik. So baie dankie aan die gesin. Your comment at the beginning, Darlene, when you, and now my Afrikaans time is definitely up. The comment you made at the beginning where you spoke about your dad, and the fact that the memory brings back an emotional moment each time really confirms for us that, in fact, he becomes an ancestor in this community in the way that we have come to respect in African culture. This idea of Amadrozi, the idea that he probably is with you all the time, and so we want to honor that memory of him and the contribution he's made in your development. So thanks for sharing that story and that tender moment. Every time I come to an inaugural lecture, because it is a time when the university offers the opportunity for the intersection between the academy, those who regard themselves as scholars, and those who receive the scholarship in the community. And so today has been one of those really exceptional moments where the speaker in the inaugural has been able to weave for us these multi-dimensions of who we are when we're clinical scientists. And so there are three things I just want to reflect on here. I mean, the first one I want to honor is your description of yourself as patient. And I think that those are such significant moments in our journey. And I suspect enable that moment where you allowed an anesthetist to put something in your trachea and allow them to fiddle. I was thinking a little bit coming from anesthesia as I do that the chat GPT thing of putting the mask on the anesthetist was really a surgical communication. Can you just calm down? Which is something that surgeons often say. So again, today has been a unique thing in listening to Darlene's speech because she spoke about the people in the room. And I do want to honor the patients that have come today. You may not want to just put your hands up so people can see, but I want to honor you in a way that really, thank you very much, but the stories that Darlene has told about the change, the difference she has made in your life. Because that's the business of what we're about. If we're not making a difference, then I think it's pointless, all the scholarship that we have. So I just want to honor Darlene the way in which you wove your talk around the lives who've been substantially changed. And yes, they're one-on-one events, but they are the things upon which we learn. But what has struck me at the inaugural lecture again and again over this last time is that we only become experts in the way that we are in South Africa because of the significant vulnerability of our patients. We're only so good because our patients come to us so sick. And it's a real tension as we reflect on what is the purpose of a professoriate in a country such as ours. It is about trying to look at systemic change that we need to engage with. And then something you slipped in halfway through, Darlene, was the idea that Karl Storz is in the room, members of the Karl Storz company. But I also want to honor that you recognize the contribution that the private sector does to the work that we do, or that you do, particularly in the surgical disciplines. And it's not often that we can, as university establishment, sit in the same room with the trade, as we often call them. But I think that Karl Storz's contribution in this airway fellowship goes way beyond our traditional views of the trade. But let me conclude then, adding to Darlene's invitation to refreshments afterwards. I think that something that referred to as rock star, but I think the real rock stars are those who have been able to translate their individual expertise and exceptionalism into the practice of medicine that changes the way people can live. And so it's almost of rock starness and much more. One becomes so much more than we imagined at the beginning. But thank you for joining us, and thank you to all of you. I recognize tonight that it feels somehow that there are many more people from the private sector here tonight than is traditional at inaugural lectures. I just feel that there are many more EMTs, I suspect, in private than there are in the department. And I want to honor that because it's, again, not often that the town and gown divide is easily crossed. And I think in disciplines such as ENT, that happens increasingly. So thank you very much for your attendance here. Thank you, Darlene, for an amazing journey, story of a journey, because it is stories that help us remember who we've been, but also help us craft the promise that we must make to a future generation. So thank you very much. Stand as the academic presentation leads, and he will be first and he join us in the A5 retreat.